So it's my pleasure today to introduce Dr. Lauren Osborne, who graduated from actually Weill Cornell. That's pretty cool. And received her psychiatric training at Columbia. So she's really New York centric. And she completed both her clinical and research fellowships in women's mental health and is an expert on the diagnosis and treatment of mood and anxiety disorders, especially during pregnancy, the postpartum and premenstrual period, and perimenopause. So this is a perfect talk for us. Dr. Osborne is an associate professor of OBGYN and of psychiatry and serves as the vice chair of clinical research in the Department of Obstetrics and Gynecology at Weill Cornell Medicine. And her research is really on this perinatal mental illness and focuses on models of care and on biological mechanisms and biomarkers with a focus on neurosteroids, which she'll tell us about today, and the immune system. And she runs is it PIPI lab? Is that how you say
Pippi,
it? I
like
love
Pippi
that.
Longstocking.
Oh my gosh, I'm always looking for great acronyms. That is like the best one I think I've seen for a while. And it's psychoneuroimmunology in pregnancy and postpartum. So that's amazing. And Dr. Osborne's clinical work consists of collaborative care for perinatal mental health within OBGYN. She's also the president-elect of the MARS of North America, founder and chair of the National Curriculum in Reproductive Psychiatry, a free web-based standardized curriculum, and editor of the APA textbook of women's reproductive mental health. That's amazing. And her work has been supported by lots of different outlets, Brain and Behavior Foundation, Doris Duke Foundation, American Board of Psychiatry and Neurology, Department of Defense, and NIMH, and NICHD. So please go ahead and share your slides. We're super excited to have you today.
Great, thank you so much. Okay, hold on a second. It says sharing is not turned on.
I'll allow it. Go ahead.
Um,
You should be good now.
there we go. Okay. Okay, so I'm really thrilled to be here. As I was saying before we got started, really great always to make connections with other people doing research on brain health. And I do it from a very different lens. I'm a psychiatrist who's embedded in an OB/GYN department, so that gives me all kinds of different perspectives on what's going on. I don't have any financial conflicts with commercial interests. I do have a lot of funding that supported the work I'll present, but I'll acknowledge that at the end. So what am I going to try to talk to you about today? I want everybody to understand at the end of this how neuroactive steroids act on the GABA-A receptor, which is the primary way in which they act during the perinatal period, how they change across the peripartum and also across the menstrual cycle in ways that have effects for mental health, and then how mood and anxiety symptoms may be related to those fluctuating levels of neuroactive steroids at times of reproductive transition. And then finally, there's a little bit at the end about how we can use synthetic neuroactive steroids to treat psychiatric illness. What's the context? Why am I even talking about the idea of neuroactive steroids in perinatal mental health? This is one of the more depressing graphs that I show in most of my slides, which is US maternal mortality. As you can see, the US has the highest rate in any developed country. And whereas other countries are staying relatively stable and flat, ours is just going up and up. And most of that increase, or a lot of that increase in recent years, has been due to mental health conditions. Mental health conditions are the leading cause of pregnancy-related death. Just going to say that again. Mental health conditions are the leading cause of pregnancy-related death. The vast majority of those deaths are preventable. And there are deaths due to suicide and also due to substance use disorders and overdose, essentially, but all preventable. And we don't do a very good job of preventing them. Why? Well, we don't even do a good job of identifying who's having a perinatal mood or anxiety disorder. So this is a graph from a paper that came out a number of years ago that I still cling to as one of my favorite illustrations of what we're doing wrong in identifying and treating women with perinatal mood and anxiety disorders. So this is all women with depression. The gray is antenatal. The black is postpartum. So if we start over here looking at all women who have depression, either antenatally or postpartum, of that 100% of women, we only identify about half of antenatally and even fewer than half in the postpartum. We only treat an even smaller number of those. We adequately treat an even smaller number, and the number that we actually treat all the way to remission, that figure is about 6% for antenatal depression and 3% for postpartum depression. I don't think we would accept that kind of rate of treatment for pretty much any other illness, whether it affected men or women. And I think it's an example of the stigma we have about mental health conditions, but it's also an example of the fact that we don't really do a very good job understanding who's going to be at risk for these conditions. Obviously, there are lots of things that contribute to perinatal depression and anxiety. It's not, although I'm talking to you today about biology, it is certainly not just a biological phenomenon. Everything that I've listed on this slide has something to do with some people's susceptibility. And of course, psychosocial reasons are paramount in the perinatal period. People are making a transition in their role, a transition in their relationships, and that has a lot to do with things. But there are biological reasons too, and that's what I want to talk to you about today. What do we know about those biological factors? Well, not nearly as much as we should. Everything that I've listed here in a bubble is something that has some kind of level of research ongoing to try to determine what its role is in the biological etiology of perinatal mood and anxiety disorders. So obviously the stress response system, the serotonin system, oxytocin is being examined as well. The two things that I really focus on are this vulnerability to hormonal change and immune system dysregulation. And today we're going to focus in on hormonal change. So one of the things I like to point out is that word vulnerability, though, because everybody who gives birth goes through the same hormonal cliff, right? Estrogen and progesterone rise enormously across pregnancy, crash down within 24 hours of giving birth. Every woman goes through that, but not every woman develops postpartum depression. So it's a vulnerability to hormone change rather than the hormone change itself. So why do we talk about neuroactive steroids? I just mentioned estrogen and progesterone. We think that the reason people have vulnerability to changes in estrogen and progesterone largely has to do with metabolites that are active on the brain. And I'm going to talk to you today about primarily those metabolites of progesterone. So all of these molecules are derived from cholesterol. I use the word neuroactive, meaning it's active on the brain. Some of them are formed in the brain, some of them are formed in the periphery, and then can get through to the brain. So whether they're formed periphery or in the brain doesn't really matter if they're active on the brain. You'll hear the term neurosteroids. That means they're produced in the brain. Neuroactive is just a more encompassing term. So as I mentioned, they're all derived from cholesterol, but the ones that we have data on in perinatal mental health, and the ones I'm going to focus on today, are those that are derived from progesterone. So you can see here, progesterone goes down a pathway to a number of different molecules. This is a very simplistic pathway. I'm going to show you a more complicated one later on, but we will focus a lot today on allopregnanolone, which is probably the best studied of these neuroactive steroid metabolites of progesterone. So why neuroactive steroid? Why does that have something to do with perinatal mental health? Well, the reason is because of how they act on the brain, and they are active primarily at the GABA A receptor. So the GABA A receptor, I often say in talks, it's my favorite receptor. It is my favorite receptor. It is a 5-channel receptor that is the site for many different drugs that are active on the brain to bind. The most obvious one is alcohol. So if you want to ever think about what does the GABA receptor do, think about that calm, relaxed feeling you might have after you have a glass of wine. That's the GABA receptor in action. So it's the receptor for the major inhibitory neurotransmitter GABA, but all of these other drugs are active on it too. Benzodiazepines, so things like lorazepam, alprazolam, barbiturates, and then, of course, the neuroactive steroids. But what I want you to notice from this picture is that they all have arrows to different places on the GABA receptor. So it's a 5-channel receptor, and each of these drugs attaches in a different place. And that's going to become important when we think about their activity in terms of perinatal mental health. I want to also mention that the GABA A receptor is not the only place for neuroactive steroids to bind, and we can't let go of the fact that there are 3 other key places where they may bind: NMDA receptors, T-type channel, calcium channel receptors, and then also the TLR4 complex. And all of those are things that may lead to antidepressant effects or calming and inhibitory effects as well. But the GABA A receptor is the one, A, which we think is the most important, and B, about which we have the most evidence. So I'm going to really focus there. So what happens in a stressful situation? How do the neuroactive steroids, endogenous neuroactive steroids, kick in? Well, if you think about going through a stressful event, what happens to your body when you undergo a stressful event? And I'm not talking now about in the context of any kind of mental illness, just any person going through a stressful event. what happens actually, GABAergic transmission through that receptor goes down when you have a stressful event, and that makes your anxiety go up. Because remember, the GABA receptor, anything through that receptor gives you this calm, inhibited feeling. And if you have transmission through that receptor going down, then anxiety is going to go up. That's a signal for your inhibitory neuroactive steroids that are endogenous to increase, to go stimulate that receptor to restore you to a place of calm. And so when that happens, those inhibitory neuroactive steroids go up, transmission through the GABA receptor goes up, and your anxiety comes down. So that's the cycle that we're all supposed to go through as healthy people when we undergo a stressful situation. But we know that people who have chronic mental illnesses have alterations in that system. So, what I described to you before of the kind of normal reaction to a stressful event, that relies on you being able to engage all of those elements of that feedback loop. But people who have chronic mental illnesses like chronic depression actually have lower levels of those inhibitory neuroactive steroids. So if you're a person who has a lower level at baseline of those inhibitory neuroactive steroids, when you go through that stressful event and you're supposed to kick in that feedback loop that sends those inhibitory neuroactive steroids to attach to the GABA A receptor and return you to that place of calm, if your level of that is lower, that may not happen. We also have data that show that antidepressants, including SSRIs, will actually reverse those low levels. So people with chronic depression have been given SSRIs. They've had inhibitory neuroactive steroids measured before and after the administration of the medication, and the medication will increase those levels. So perhaps restoring them to a place where they can undergo that usual feedback loop that they're supposed to be undergoing. So that's in chronic depression outside of the perinatal period. But when we start thinking about reproductive physiology and how that intersects with this, things get a little bit more challenging and more complicated. Some of the earliest information we had about how neuroactive steroids may be interacting with mood symptoms comes from premenstrual dysphoric disorder and premenstrual syndrome. And so remember what I said about chronic depression, it was low levels of inhibitory neuroactive steroids that were associated with low mood. When we look at PMDD, we don't see that same pattern. So if we look here over on what's, I guess, my left, I guess it's your left also of the screen, we see from a study from a number of years ago that shows irritability score on the top for people with PMDD. And allopregnanolone, remember, that's one of those metabolites of progesterone that serves as a neuroactive steroid. So allopregnanolone on the bottom, irritability on the top, and we're going across the days of the menstrual cycle. So when people with PMDD have symptoms, those always occur in the luteal phase, so the last 2 weeks of the cycle, and really ratcheted up in the last 1 week of the cycle, so the week before menses begin. And we see that with the irritability scores here. So we have somebody whose irritability scores come down sharply at the beginning of bleeding, stay down, stay low during the whole follicular phase. And then as soon as ovulation occurs, that irritability starts to ramp up, gets to about day 21. Remember, that's a week before the beginning of menses, but it doesn't stop there. It keeps ramping up and keeps ramping up until the end of the cycle and then suddenly crashes down again. So irritability is going up all throughout the luteal phase. But what's happening to allopregnanolone in that time? Well, you'd want to say, well, it's got to be low, right? Because that's what happens in people with depression. No, it's not low. It's high, but it's not high in the same way that the irritability is high. So irritability is going up all the way through the luteal phase. Allopregnanolone goes up until about day 21 and then starts to come down. So it seems to be that this irritability has to do with sensitivity to that fluctuation rather than to high or low levels themselves. There's some evidence that the steepness of the descent may be involved in people's vulnerability to symptomatology, but we don't have a lot of good evidence that the actual absolute levels of allopregnanolone are what matter. Instead, what matters is that fluctuation in people's vulnerability. Some people have posited that maybe there's this inverted U-shaped idea where low levels or high level, either very low or very high levels, are associated with symptoms. And there's kind of a sweet spot in the middle, the sort of physiological state of the luteal phase that you're supposed to be in. And if you're a person with very low or very high levels, either way, you may develop symptoms. We're not entirely sure, but it's definitely something that has to do with the fluctuation. So chronic depression is low levels. PMDD is vulnerability to change. What about pregnancy and postpartum? What is that like? Is it more like depression outside of the perinatal, outside of the reproductive period? Is it more like PMDD, or is it yet a third thing? We actually have a lot of evidence. So I want to just remind us, going back to what the neuroactive steroids are, because I'm going to focus from now on pretty much entirely on allopregnanolone because that's where the data are. But I don't want to lose track of the fact that there are lots of other neuroactive steroids. This graph shows the ones in yellow are inhibitory neuroactive steroids. So those are those that potentiate the GABA receptor, have the same effect as GABA. Whereas those in blue are the opposite. They're excitatory neuroactive steroids. They inhibit the inhibitor, so they'll have the opposite effect. And we actually have data on a number of these other molecules as well. Allotetrahydrodoc and pregnenolone both have properties very similar to allo, whereas DHEA sulfate, which is one of the excitatory ones, has actions opposite to that. So lots of other data in other places, but by far the majority of it for the perinatal period is allopregnanolone, and we'll focus on that. So allopregnanolone is the 3-alpha-5-alpha reduced metabolite of progesterone. This is what it looks like. I once saw somebody with a necklace made from of the serotonin molecule that you've gotten on Etsy, and I'm dying to do that for allopregnanolone. I have yet to actually get it together to do it. So what does allopregnanolone do? Well, I've already mentioned that it's an inhibitory neuroactive steroid, but what does that mean its functions are in terms of the body? So it's a regulator of emotions. It's anxiolytic, but it's also involved in a number of other things. It's involved in myelination. So if you don't have sufficient allopregnanolone, you're not going to have sufficient myelination. It regulates inflammation, and there's a very strong crosstalk between the neuroactive steroid system and the inflammatory system, and pregnancy just makes that more complicated. It regulates the HPA axis, and it regulates autophagy. One of the areas of research that I'm not going to talk to you about today is some data that I'm working on in extracellular vesicles that are produced by monocytes and macrophages that are actually predictive of who's going to go on to develop postpartum depression. And what we've seen in those extracellular vesicles is that the mRNA communication, which is so different between those who do and do not develop postpartum depression, is indicative of reduced autophagy in the women who go on to develop postpartum depression. So there's a link there with allopregnanolone as well. So what happens to allopregnanolone in normal, healthy pregnancy? So again, not talking about a mood or anxiety disorder at this point, just normal, healthy pregnancy. Well, progesterone goes up many, many fold across pregnancy, and allopregnanolone is a metabolite of progesterone. So of course, it's going to go up as well, about 7 to 9 times across the course of pregnancy. And then it begins to drop toward the end of pregnancy. So progesterone goes up all the way until you deliver and then crashes. Allopregnanolone is different. It actually starts to dip down before the end of pregnancy. So this is the ratio of allopregnanolone to its immediate predecessor in that progesterone metabolic pathway. And you can see up until 30 weeks pregnancy, we're driving toward the endpoint of that metabolism. We're driving toward allopregnanolone. But then by the end of pregnancy, that ratio has shifted. So we're pulling back a little bit and not going all the way to the endpoint of that pathway. Then after birth, the ratios of allopregnanolone will return to normal by about 6 weeks postpartum. But the other thing that's really important to remember as we're talking about it is that the GABA A receptor subunit binding capacity changes along with those levels of allopregnanolone. And I'm going to spend a lot of time talking about that because it's really important to the way things function. Within 48 hours after delivery, that GABA receptor is supposed to bounce back to pre-pregnancy condition. And we think it's this combination of dysregulation in both the production of allopregnanolone and in the receptor plasticity that may be responsible for mood and anxiety disorders that are based in neuroactive steroid dysregulation, which not all of them are. So what do we know in terms of the data? So early data on allopregnanolone and it's associated with mood and anxiety disorders in pregnancy and postpartum was really mixed. So we had a bunch of studies that said, oh, it's just like depression. If you have low allopregnanolone, that's associated with symptoms of depression. And that was when measuring allopregnanolone in pregnancy, symptoms of depression in pregnancy, right? Then there were other studies that seemed to find that there were blunted neuroactive steroid responses to stress that were associated with negative affect in pregnancy. So again, measuring that in pregnancy for something else that's happening in pregnancy. Then there was one study that looked at the neuroactive steroids and resting state functional connectivity in postpartum depression and couldn't really find any relationship between the neuroactive steroids and the mood or anxiety symptoms. We had a major advance a number of years ago with Christina Deligianidis' group, and she looked at neuroactive steroids across the peripartum. And what was really important and interesting about her study was that she didn't just look at allopregnanolone, she examined multiple neuroactive steroids. She examined them across pregnancy and the postpartum. She used longitudinal measures of both mood and anxiety symptoms and of the neuroactive steroids. And she used LCMS. Some of the previous studies have been done using ELISA, which is less precise and which may get you allopregnanolone and some other molecules that are kind of similar to allopregnanolone. But this study, although it had those great advances, it also had some key things about it that we still don't have questions to. So this study defined people as being at risk for perinatal depression, and it wasn't specific about what was the timing of onset of those symptoms. So she looked at average levels of the neuroactive steroids across time and average levels of symptoms across time. So you didn't have a sense of like when are the symptoms arising in relationship to what the levels of the neuroactive steroids are. And she looked at kind of these mean levels rather than change across time. So that left still a lot of room for other people to figure things out. We also have some evidence that there may be a genetic contribution to the fact of dysregulation of neuroactive steroids. This was a paper done in Sweden a number of years ago that looked at the gene that controls the enzyme that controls the major rate limiting step in the production of allopregnanolone, and found that people who had who were homozygous for a minor allele of a SNP on this gene had actually a much steeper increase of their depression scores across pregnancy. So you can see that in the top graph here. These are the people with the open black dots. Those are the people who were homozygous for that minor allele. And you can see that they just had this much steeper increase in their depressive symptoms across pregnancy. And there were two different alleles that they tested. This one is the more significant one. So there may be some genetic reason that people's levels of neuroactive steroids are out of whack, but this work is in relatively early days yet, I would say. So I want to go back to the concept that it's not just allopregnanolone, but its relationship with the other molecules in the pathway and its relationship with the receptor that's so important. So I showed you before that allopregnanolone begins to decrease before progesterone does at the end of pregnancy. So early in pregnancy, we're shunting all the way through to that endpoint of allopregnanolone. Later in pregnancy, we're kind of stopping here at this 5-alpha DHP, which is this intermediary molecule. And it becomes even more complicated because that molecule actually inhibits the GABA receptor. So you don't have enough of the positive allosteric modulator, which is allopregnanolone, and you may have more of something that's actually a negative allosteric modulator. And in addition, I mentioned that the receptor changes its conformation during pregnancy. It's hard to find a good picture of the receptor in pregnancy, so I'm showing you one in stress instead of in pregnancy, but you'll get the idea. So it's a pentameric receptor. It has 5 channels, and over here on the left, this is what the channels usually look like. 2 betas, an alpha, another alpha that's composed of different subunits, and a gamma unit. During pregnancy, what happens is, during times of stress, you have another unit, the delta unit, that gets slipped in at times of stress, and that delta unit is exquisitely sensitive to the neuroactive steroids. So when you have that delta subunit expressed, the neuroactive steroids are going to bind really strongly to that receptor. So that makes sense during this period of protracted stress, right? When you have the endogenous neuroactive steroids are increasing to potentiate things through the GABA receptor, you want something that is really going to bind those with strength. But in pregnancy, would we want something that's really going to bind allopregnanolone or the other neuroactive steroids with great strength during pregnancy? No, bad idea. Because remember, those molecules go up 7 to 9 times across the course of pregnancy. If we had that delta subunit at its usual strength during pregnancy, people would just be asleep all of pregnancy because it's a very sedating molecule. It would bind to this delta subunit and it would just knock you out. So you have to do something to change it during pregnancy. And so the body has come up with this great idea of downregulating that delta subunit during pregnancy and upregulating the gamma unit instead. So that decreases the sensitivity of the receptor to those endogenous neuroactive steroids. And we know that that delta receptor, though, is key to things returning to normal in the postpartum. And we know that from this key study that was done by Jamie McGuire in 2008, where she took two groups of mice. There were virgin mice and postpartum mice. There were wild type and those in whom she knocked out that delta subunit of the receptor. And when she compared those two groups of mice, the wild type to the delta knockout, in the virgin mice, made no difference. So you can knock out that delta subunit for a virgin mouse, and it will not make any difference in your mood or anxiety like symptoms. But if you knock out that delta receptor in a postpartum mouse, you have big trouble. So you can see here immobility time, which is this proxy in mice of a depression-like symptom, right? If you knock it out in a postpartum mouse, suddenly you have a great increase in those depressive-like symptoms in the postpartum mouse. So that told us that in the postpartum, we have to be able to bounce back to that normal delta subunit, or something else is going to happen. And that was the first key that we had, that it was the crosstalk or the relationship between not just the neuroactive steroid levels, but what they were doing to the receptor that was so important. And this is a great, I think, a great figure from some colleagues of mine. They did a review paper a couple of years ago where they just basically walked us through the whole thing to describe what it means. So here's the GABA A receptor. In normal times, usually you have either that delta or that gamma, the delta being especially sensitive to neuroactive steroids. Sorry, I have to keep moving your faces. And then during pregnancy, the delta subunit is downregulated. That decreases sensitivity to neuroactive steroids. It modulates GABA signaling. And in the postpartum, we're supposed to bounce back within 48 hours, increase that delta subunit, increase sensitivity, and we restore that sensitivity to neuroactive steroids. But if we don't do that, if we have any kind of disruption, and whether the disruption comes in terms of the receptor subunits not changing in the first place, not changing back the way they're supposed to, or the levels of neuroactive steroids, which are in fact a signal for the receptor to make those changes, any kind of dysregulation there may lead to depressive-like symptoms and abnormal maternal behavior. So what has our group done to try to, shed a little more light onto this story? It's baby steps, I have to say, but we're trying. So the very first study we did, and this was before I came to Cornell when I was at Johns Hopkins, and this was a study where it was my mentor there, Jennifer Payne, had done her K Award in a group of 62 women, all of whom had a diagnosis of a mood disorder. And she followed them through pregnancy and up to 3 months postpartum. It was a naturalistic study. They could use whatever medications they used. They just had treatment as usual. And she was following them to just sort of observe the course of symptoms over time. And when I came to Hopkins, I said, what if we measured allopregnanolone? You've got the blood in the freezer. Let's take a look at this. So we did allopregnanolone at the time by ELISA, which I already told you was not a good idea to do, but it's much cheaper. And it was the first study that we did. So we looked using ELISA, which means what we really measured was allopregnanolone and possibly also pregnanolone. It's a little bit uncertain. And what did we find when we measured these things across time? So first of all, I should say that there are a lot of caveats to this study. It was blood that was sitting in the freezer. It was a relatively older, relatively highly educated, highly partnered group of women. And about half of them developed postpartum depression. But remember that all of them had had a prior mood disorder. 70% of those major depressive disorder, 30% bipolar disorder. There's a lot of lack of clarity here, like mixing different diagnoses, right? But we knew for a fact that about half of them were euthymic in the postpartum, half developed postpartum depression. And what did we find? We found a really strong and clear signal for people who had low allopregnanolone in the second trimester developing postpartum depression. So those whose allopregnanolone was low second trimester, went on to develop postpartum depression, even if they were well in the second trimester. And for every additional nanogram per milliliter of allo that they had in the second trimester, that reduced their odds of developing PPD by about 63%. So obviously, this isn't something that's happening right away. This is second trimester. We're measuring many months later in the postpartum. So clearly, there isn't a direct effect of the allo on the mood, but something that's being, some chain of events that's being set into motion in the second trimester by low allo. Possibly, likely, probably it's that receptor plasticity, right? So the low allo is not sending the right signals for the receptor to transform the way it's supposed to. So we decided to try to replicate this using a different group of people. So this was a combined cohort of one of my studies and one of Jen Payne's studies. We had 124 women with allopregnanolone and mood and anxiety measures at 2 time points in pregnancy and at 6 weeks postpartum, and slightly different numbers depending on what analysis we did, just in terms of who had missing blood draws or missing psych data. And we first set out to try to replicate that prior finding. Like, could we again show that their low allopregnanolone early in pregnancy predicted postpartum depression? And this time we had measures not just of depression, but also of anxiety. And so we're looking here at the EPDS score, which is the depression scale score, this STAI state score, so that's the Spielberg state trait. We looked at the state score for that. And then the PASS, which is the perinatal anxiety screening scale, so a more specific to pregnancy type of anxiety scale. And what we found, you can see here, the shape of the curve is exactly the same, right? So the lower your allopregnanolone in the second trimester, the higher your EPDS at the 6 months postpartum, right? So we were able to replicate that. And it seemed to be true for both depression and anxiety. So we replicated it. I should say we didn't exactly replicate, because it's not exactly the same measures. Like, we had a depression score. We didn't have a clinician diagnosis of depression as we did in the previous one. We also wanted to look at concurrent relationships. So in the previous study, we hadn't looked at that. Now we wanted to look at, okay, we know that there's some kind of predictive relationship. What if we look at that relationship happening at the same time? And so we looked at, and we also wanted to look more deeply into anxiety. Everything that we had been looking at so far was depression. So my study that I did there was just for biological mechanisms of anxiety, and the people in this study had no depression at all. So they were excluded from the study if they had depression. And what we found when we combined these two groups of people, so the group of people who had both depression and anxiety, the group of people who had anxiety, we tried to combine them just to increase our sample size. And what we found was that whether or not we could replicate that relationship that we saw before in the group of people all of whom had mood disorders really depended on the history of a mood disorder. So here we have the blue are people who have a history of a mood disorder, and the red are people who do not have a history of a mood disorder. And if you look here at the blue lines, they look just like the line from that first study, right? Where we were seeing that very same nice, neat curve that shows us that higher depression scores are associated with lower allopregnanolone in the second trimester. But the people who don't have a history of a mood disorder are showing a completely different pattern. So we're not sure from that first study, were we really showing something that had to do with the rate of postpartum depression? Or were we showing something that was a factor of people who have a mood disorder, even if that mood disorder isn't active at that moment? We also found that sleep made a huge difference. So once we factored sleep in, a lot of our other associations were reduced just by the fact of including sleep. It makes sense. Sleep affects inflammation, sleep affects hormonal states, and sleep is something that's really dysregulated in postpartum depression. So again, are we showing something related to postpartum depression? Are we showing something that's a factor that people with mood disorders have, and getting bad sleep makes it worse? Unclear. Then we also, as I mentioned, wanted to look at concurrent relationships. So what we had before was something predictive, and was something that was clearly setting some chain into motion. Could we see something if we just looked purely the way we've looked in major depression outside the perinatal period, where we look at levels and symptoms at the same time? And here we found an interesting pattern where if we looked at the second trimester and mood symptoms at that time point, we saw the same kind of pattern we've seen in the predictive things where higher EPDS was associated with lower allopregnanolone. But in the third trimester, we didn't see any relationship at all. And at 6 weeks postpartum, we saw the opposite relationship, where higher allopregnanolone was associated with higher EPDS scores. So this looks an awful lot like the opposite of that inverted U-shaped curve we had in PMDD, right? Where we saw that both low and high symptoms could be associated with symptomatology. And there was this sweet spot in the middle. So, and then finally, in this group of studies, before I get on to the more recent work, we also looked in changes from the third trimester into 6 weeks postpartum. So this is from that study that's purely anxiety, nobody with depression. And what we found there was that as we went from the third trimester into 6 weeks postpartum, this graph is showing you the ratio of allopregnanolone to progesterone. And you see they're going along pretty close together during pregnancy. And then in the postpartum, the women who are in red are those who don't have anxiety. The women who are in, the women who are in red are the women who do have anxiety. The women in blue are the ones who don't have anxiety. And you can see that the healthy thing to do in the postpartum is as soon as you give birth, your allopregnanolone to progesterone ratio plummets and goes back to normal by 6 weeks postpartum. And the women who are anxious are not mounting that. So they're staying with their allopregnanolone high. So remember, high, not low, so different from before, but again, some kind of dysregulation that's associated with symptomatology. So out of that group of studies, what did we conclude and what questions did we have and where else did we think we could go next with the work? So we felt we were pretty confident saying that lower allopregnanolone early in pregnancy could predict depression or anxiety in the postpartum, but it also seemed that that relationship really might be driven by those with a mood history. I didn't mention before, but we did actually incorporate medication use into our models to make sure that that didn't change things because SSRIs do affect allopregnanolone levels. We had only a minority of people taking medications. It didn't make a difference, but sleep did make a huge difference. And we also seem to see that the relationship between allopregnanolone and those mood and anxiety symptoms differed across the peripartum. But it just left us with a whole bunch of questions like, what is the relationship to the rest of the pathway that's not allopregnanolone? Does anxiety differ from depression? Does the population matter? Some of my immune system work, I've come up with radically different answers depending on what population I look in. So does that matter? Would it matter if we did better methods of measuring allopregnanolone? So not ELISA, but a more specific GCMS or LCMS. And then how does it connect to other systems like the immune system? So I want to go back again to that idea of the other molecules in the pathway, to the whole progesterone metabolic pathway. I've talked almost exclusively about allopregnanolone. I mentioned that with ELISAs, we might also be picking up pregnanolone. Those are both positive allosteric modulators of the GABA-A receptor. But I haven't talked about these two molecules, isoallopregnanolone and epipregnanolone, which are stereoisomers of allo and pregnanolone, and they are negative allosteric modulators, just like these predecessor molecules are. So we have to think about those too, because if you're metabolizing down to allopregnanolone and there can be a shift back and forth between allo and isoallo, then your shift between negative and positive modulators of the GABA-A receptor may be constantly shifting. And if you don't consider that, if you look only at the positive ones, you may not be getting a full picture. So the next study we did was we tried to look at all of it and to include the negative modulators as well as the positive modulators. And what we found in this study is we also really wanted to overcome some of the limitations of some of the previous research, which, as I said, looked longitudinally, but kind of got means over time and looked at symptoms over time. Because what our group is really interested in doing is figuring out if we can find, is there a predictive biomarker of who's going to be at risk? The reason, because back in those first slides I told you, when we do a really bad job of identifying people who are at risk, if we had a better way of identifying who's at risk, particularly for biologically based postpartum depression, which again, not the only kind, but the kind I happen to be really interested in, if we could predict who's at risk, then maybe we could take some of the really scarce resources we have and apply them to those women at risk and have preventive strategies. So in this pathway, we wanted to look at the balance between those positive and negative modulators of the GABA A receptor. And what I'm showing you here is the log odds of postpartum depression on the y-axis. And then on the x-axis, three different things. So this is just progesterone here in A. B is the pregnenolone to progesterone ratio, so a positive allosteric modulator in relationship to its predecessor in the pathway. And then finally down here, the isoallopregnanolone to pregnenolone ratio. So that's the ratio of a negative modulator to a positive modulator. All of these measured in the third trimester. And what we found was that the higher your progesterone and the higher your level of that negative to positive balance, the greater your odds were of developing postpartum depression. And these are for women who are euthymic in pregnancy, develop postpartum depression in that pure biological way with onset within 4 to 6 weeks after childbirth. And then similarly, the lower your ratio of pregnenolone, a positive modulator, to progesterone, its predecessor, the higher your chances were of developing postpartum depression. And these were strong relationships. They survived. When we initially did it, we've had positive relationships for everything along the pathway. Once we corrected for multiple comparisons, these are the three that stuck. And so to us, what this says is the women who are euthymic in pregnancy, something is happening during pregnancy that is dysregulating. There's some dysregulation of this whole progesterone metabolic pathway that is resulting in them either getting stuck at the progesterone phase or having an imbalance of the negative to the positive, with the result that their levels of neuroactive steroids are altered, and therefore the plasticity of the receptor is affected as well. What are the other steps in the pathway that we have to understand how that works? We have to understand where it's happening, which enzyme is flawed. Is there a genetic contribution? What exactly is happening to the GABA A receptor? We can theorize that this has to do with the plasticity of the receptor, but what is happening? Well, fortunately, the Department of Defense decided to spend some money on us instead of on bombs. And we have a grant now where we are looking at the enzymes along that pathway, and we're looking at the subunits of the GABA receptor, which, believe it or not, you can measure in peripheral blood. So ask me in about 5 years, and I hope to have some more answers there. I'm going to show you just one other thing about that of another study that we've done along these same lines, and then I'm going to go to a little bit of what's the practical application for all of this. So I mentioned before that we're not sure whether depression and anxiety would have the same profile. Increasingly, it looks like they don't have the same profile, that both of them can be affected by neuroactive steroid dysregulation, but it's not the same. And this is a study that I did in Pakistan. I mentioned before that population also seems to make a difference. And this was a study where it was anxiety alone. You could not have depression to participate in this study. And this is showing you again that negative to positive ratio. This is actually the relationship between the negative allosteric modulators and their predecessor, progesterone, at the third trimester, and what's happening with anxiety in the postpartum. And what you can see here is the anxiety was measured with the HADS anxiety scale. So the higher your relationship of those negative allosteric modulators to progesterone at the third trimester, the higher your anxiety in the postpartum. So in this case, depression and anxiety seem to be behaving relatively similarly, but I think we need a lot more work to disentangle that. So what does this all mean on a practical level? I mentioned before that my passion is really to try to develop a predictive biomarker that's going to predict who's at risk. But also, one of the things you can think about is, well, can we have new treatments based on the fact of understanding this biology? All postpartum depression is not based in this pathway, but for women for whom it is, there may be actual practical clinical implications. And in 2019, for the first time ever, the FDA approved a drug for postpartum depression. I count this as a victory in a couple of ways. One, the FDA acknowledged that postpartum depression might not be just depression that happens to happen in the postpartum period, that there might be a distinctive biology to postpartum depression. So I consider that a validation of all those years of research in allopregnanolone, a few of which are mine, but most of which are not mine, or many other people for many years. And I think it's a so I think it's a victory for that science, and I think it is a victory to acknowledge the fact that women in the postpartum may have a unique disorder. But there were problems with this drug. It was an IV drug. You had to be inpatient to receive it, which means you had to have a bed in a psychiatric unit, which is something that's hard to obtain, or in a general medical or obstetric unit. And the drug was approved in 2019, which means it came on the market in the fall of 2020, or sorry, in the early winter of 2020. Something else happened in the early winter of 2020. And at the time, I was working at Johns Hopkins, and we had planned a brexanolone unit so that we could administer the drug to a small group of women at a time, inpatient. But then COVID happened, and the brexanolone unit got taken over to become a COVID unit. And so it really was hard to get the drug up and running in a lot of places because of that unfortunate timing. What does brexanolone do? Well, brexanolone is a proprietary IV formulation of allopregnanolone. It's just a synthetic version of allopregnanolone. And the theory is that it helps to restore you essentially to a third trimester level of allopregnanolone. It might not make intuitive sense that giving allopregnanolone would help these disorders, because I showed you before that the women who were having symptoms in the postpartum actually had higher levels of allopregnanolone. The theory is, instead, if we reset you and put you back into the third trimester, it gives your body more time to make that conformational change that it needs to make in the postpartum to the receptor, and that may be what's restoring function. It's a theory. We don't really know why it works, but we know that it was this, as I said, a 60-hour IV infusion. People had to be hospitalized. And of course, in the United States, that means they had to leave their baby behind. In other countries, you can be hospitalized with your baby, but not here. So it was a very difficult drug to administer. And there's been some criticism. There was a strong placebo effect with the drug. Was that just because women were leaving the baby behind and getting 3 hours of sleep in the 3 days of sleep in the hospital? That might have been part of it, right? But a lot of other drugs also have strong placebo effects. So what do the data show? These are the studies that were done. There's 2 randomized controlled trials that compared baseline rates to post-infusion. And the main point that they measured was reduction in the Hamilton Depression Rating Scale. There were some adverse effects, mostly somnolence and dizziness. And this is what the data look when they combined all that data into one graph. You see the green line is placebo, the blue line is brexanolone. And you can see, yes, a very strong placebo effect, but what you also see is a rapid effect of drug. So within 3 days, people's symptoms are largely resolved. And that stayed out until 30 days. Even though it's a 72-hour infusion, the studies went to 30 days. So this is a much more rapid acting response than traditional antidepressants, which take 4 to 6 weeks to kick in, right? So there was a lot of excitement over the concept of this, but as I said, a lot of difficulty getting it out there into market. Because of all of that difficulty, they were working hard on developing an oral version of the same drug, that's zuranolone. It was approved in August 2023, and the company really hoped it would be approved not just for postpartum depression, but for major depressive disorder. But those trials were not convincing, and the FDA did not approve it for major depressive disorder, but did approve it for postpartum depression. So again, it's an oral drug, very similar looking data. This looks almost exactly the same as the brexanolone data, as you can see. And again, that rapid acting response, it's a drug that you take for 2 weeks and then you stop. So it's, in some ways, it's extremely appealing for postpartum moms. A lot of the objection I get when I clinically try to convince people to take an antidepressant postpartum is they ask me how long we have to take it. And I say, well, for 9 months after your symptoms remit, and then we can try to get off of it. People don't want to take a drug for 9 months or for what they think of as their whole life. They don't mind taking a drug for 2 weeks. But there are still a lot of logistical limitations to it. First of all, the data were done in women with moderate to severe postpartum depression, a very controlled sample. We have very little data on breastfeeding. It's a very soporific drug. So people are really sedated. There's a warning that you can't drive for 12 hours after taking the drug. So there really has to be somebody else available who can help with childcare at night. And I would say for the majority of my patients to whom I offer it as a possibility, the majority do not choose it because of those limitations, even though it has that rapid acting effect. It's also a drug that can only be obtained at this point from particular mail order pharmacies. and it can take a long time to get it approved and shipped. It requires prior authorization by the insurance. The patient has to respond to a phone call from the insurance company. The patient has a tiny little baby, isn't picking up the phone, so things can take a long time. And I've had a lot of people whom it's taken over a week or two to get the drug, and at that point they may as well have just started an SSRI. So I think it's been very mixed in terms of its actual practical application, but the science of it is interesting and exciting, and perhaps has some promise for the future. So I'm just going to wrap up with a couple of other things. I've talked a lot about allopregnanolone, but I've also mentioned it is not the only neuroactive steroid, and there's research out there going on on a number of other neuroactive steroid drugs. So there's been some research on DHEA, which remember is that excitatory neuroactive steroid, so it has the opposite effect. And outside of the reproductive period, but there's been some observational studies showing improvement in sexual function for postmenopausal women and some improvement in depression scales for non-reproductive midlife men and women. Pregnenolone is being studied. That is the precursor to progesterone, so it comes higher in the pathway than progesterone, and it's being studied right now for perimenopause. And then there was another ganaxolone, which is another positive allosteric modulator. It was studied for postpartum depression. It showed promise in early open label trials, but it did not sustain its effect out to 28 days. So this has never been brought to market. It has been studied also in postmenopausal women. It seems to have some effect on depressive symptoms, but again, hasn't been brought to market. And then finally, I think one of the more intriguing studies is sopranolone, which is one of those negative allosteric modulators, and it has been tried in PMDD. So it's going to have the opposite effect of allopregnanolone. And remember that graph I showed you at the beginning where irritability scores were going up, 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 up as allopregnanolone rose and then fell? Well, it turns out if you block the actions of allopregnanolone on the GABA A receptor in people with PMDD, you actually have a major effect. And that's what sopranolone does, is it blocks it. And so what we have here is total symptom scores, negative mood scores, and impairment scores for people who received the drug versus those who received the placebo. And what we're seeing is the score reduction. So you can see the gray bars, a much greater reduction in symptom scores for people for whom we blocked the actions of allopregnanolone. So I think this is really intriguing, and I'll be interested to see where this goes. So how do we wrap it all together and have a conclusion? I think it's early days yet, but I think we can definitely say that there's a substantial evidence for the role of some kind of neuroactive steroid dysregulation in the pathophysiology of reproductive mood disorders. That relationship between the neuroactive steroids and symptoms may differ according to state in your cycle and according to pregnancy state. And that definition of reproductive illness is really crucial. Like, when do the symptoms develop? When are you measuring the drug in relationship to those symptoms? It's a promising avenue for treatment, but it's really early days yet. There have been some practical problems with rolling out that treatment. And so I think we have a lot yet to learn in terms of where we could go with these data. This is just a big thank you to all the people who helped me do the work that I do. The top is my lab here at Cornell. The bottom is my former lab at Johns Hopkins, and my funding and mentors and staff are all acknowledged here. And I think we have 5 minutes left for some questions.
Thank you so much, Lauren. That was great. And very sort of inspiring and hopeful, I think, at the end there. And hopefully things can get sort of personalized. And I think that's like kind of my first question is, because there are all of these intricate sort of confounds or contributors to what is actually effective or the relationship. Is there like a way that people are looking at like now, like looking at specific person and trying to see the effect of that rather than, I know for FDA approval, obviously you have to have like group level effects, but have people done analysis of like individual trajectories?
Yeah, that it hasn't been done. And I think there are two things that we really, really need to do, both in terms of how the drugs have an effect and in terms of the endogenous effects. So in terms of the drugs, we need to see if we can use these drugs to prevent this illness, right? And we also need to see who are the people who respond to these drugs and who are the people who don't, right? This isn't the answer for all women with postpartum depression. And I can give you a clinical impression of who I think responds to these drugs and who doesn't. It would not be science. It's my clinical impression, but I have a pretty strong clinical impression, and I really want somebody to study it so that we can have those answers of what are the things that make certain people at risk and what are those individual trajectories, because the whole point of this is, precision medicine, right? This is not because, the DSM has this really wishy-washy definition of depression with perinatal onset, peripartum onset, which is like you could become depressed in pregnancy or within 4 weeks of giving birth. And that doesn't account for all the women who become depressed at 8 months postpartum, which is not biologically related. That's psychosocial, right? But it also doesn't account for the precision of that timing of childbirth, where the postpartum is just a different state than pregnancy. If you lump those two together, you're never going to be able to see what actually is causing it, because you're lumping together two things that don't belong together.
Lauren, I have just a quick question. Wonderful talk, really wonderful. And I do multiple sclerosis here at Cornell, and we should talk sometime.
Definitely.
But just thinking about the postpartum time and breastfeeding and those that, like, how does this influence it, and those that could exclusively breastfeed versus those that aren't able to, and the impact on the hormones. Have you looked at that?
Such an interesting topic, because we also know that inability to breastfeed, which affects mothers' feelings of self-efficacy, is related to development of postpartum depression, right? And we know people who successfully breastfeed, that can be related to improvements in mood, partly because of the hormones that are involved there, right? Oxytocin is the feel-good hormone, right? But nobody has really looked very closely at the relationships between the key breastfeeding hormones and these hormones. I think it's a really important thing to study. And I think particularly because we also have to think about the factor of what drugs can you use while you're breastfeeding, which can't you? We have so little data on these drugs in breastfeeding. So it's a really important area, and it just hasn't been studied enough.
Yeah, thank you.
There's one question. I know we're running out of time, but one that I thought maybe we should get to in the chat. Has allopregnanolone, oh, they're coming in. Has allopregnanolone or other neuroactive steroids been explored with postpartum psychosis?
Oh, interesting. Not really. There's one study out of UNC which has an inpatient psychiatric unit that's, babies can't stay, but they can visit a lot. So it's a perinatal specific unit. They looked at postpartum psychosis using brexanolone to treat it, but they had a very broad definition of postpartum psychosis that is not consistent with what I believe is the correct definition. So we don't really know. And these endogenous things have not really been studied with postpartum psychosis. It's such a rare disorder that it's really hard to get enough people in a study. I will say that some of the other things that we think are biomarkers for postpartum depression have been found not to exist in postpartum psychosis. So it really is a distinct disorder. And I think it's probably immune mediated. That's where most of the research is going on. But it would be really interesting to study these in PPP. Yeah.
Well, with that, I don't know if there's any last questions from our crew. I have a feeling your inbox is going to be flooded, Laura, because
always happy to have emails and chat with people.
Just, an extraordinary body of work, extraordinary way of going through and giving us sort of this deep biology, but nested within all of the other psychosocial factors. I know personally, I'm sure Nina and I want to sort of follow up in our whole maternal brain project team, because we have that kind of precision time series data starting preconception through 2 years postpartum with banked bloods. We're going to look at neuroactive steroids. We'd love to pull you on.
Oh, wow, we have to talk.
I was just texting with Laura Pritchett, Sheila Shanmugam's group. This is just, it's your framework, I think, is just exactly the right one. And we'd love to selfishly find a way to work with you, because I think you're just so brilliant. And with that, thanks everybody for attending. Everybody, the slide show is going to be up on YouTube. We'll blast it out so that everybody can watch it from there. And yes, enjoy England, and see you back in Cornell. I guess your colleagues will.
I'll be back in a couple of weeks. So
thank you so much.
Thank you so much. Thanks so much for having me. It was great to connect.
Really incredible.
Bye.